start. I think we've waited long enough.
Yeah.
Yeah. So good evening, everybody. It's a close-knit group of friends and very senior dermatologists, which is really an honor for me, on a topic that we face throughout our life. All of us have been facing atopic dermatitis right from the days when we graduated. We know that there's no atopy without itch, and the proverbs and the jokes about this we have heard, and we have been through many issues in atopic dermatitis as we matured in the field. So to put it in a nutshell, we had a great difficulty in memorizing the Hannifin and Ricas criteria, the major, the minor, and to remember all of them was quite a challenge as young postgraduates probably. And then we reached the phase where the diagnosis of atopic dermatitis was made simpler with newer criteria, for example the UK Working Party diagnostic criteria. And those were the times where atopic dermatitis was sort of being defined. And to be frank, even today, what is atopic dermatitis? Atopic dermatitis is a type of eczema, and to actually make a diagnosis is not always easy, because it's a diagnosis of exclusion many times, and unless you have a very classical pattern with a classical family history and criteria being filled, the atypical types of atopic dermatitis are pretty difficult to diagnose. So to put it in a nutshell, the challenges in atopic dermatitis, the first one is the diagnosis. The second one is to quantify the disease burden. The third one is to decide on the appropriate treatment. The fourth one is counseling the patient and the family. And the fifth one is to monitor the patient adequately to demonstrate a clear-cut improvement. And the last one is the biggest challenge is to actually maintain a patient on good enough relief with minimal flares. So let me go to the agenda. The agenda today is to talk about the epidemiology and risk factors of atopic dermatitis briefly, the patient burden, key points, the immunological pathway and the key points, and primarily focus on dupilumab and the clinical data. So the disease, simple. Diagnosis is a challenge. In the earliest phase of life, we need to consider many aspects of atopic dermatitis, including failure to thrive, combined immune deficiency, the Scott-Adams syndrome, and in rare instances even differentials like zinc deficiency. But by and large, it's a diagnosis of exclusion, having to exclude scabies, dermatophytosis, seborrheic dermatitis, and sometimes even psoriasis. Since psoriasis in children, the thickness of the plaques are not so typical. Therefore, the disease diagnosis is the first challenge for us. The second is, once we have made a diagnosis, we usually end up with empirical treatments. And the biggest challenge there is to counsel the patient and to actually monitor the patient for compliance. And the factors that affect atopic dermatitis, we know that in conjoined twins, there's nearly an 85% concordance of developing atopic dermatitis. Similarly, there's a very strong family history of atopic tendencies, including hay fever, asthma, food allergies. So it's a cluster of conditions. And during our lifespan of dermatologists, we have already learned that it's primarily a condition with the immune mechanism playing a role. So most of the treatments that we have been doing have been systemic or immune suppressions. Even the topical corticosteroids, the strong ones, the basic issue is that we are immunosuppressing the patient and finding a relief from the inflammation. Whether we use a steroid cream or ointment, or whether we are using topical calcineurin inhibitors, or whether we are using systemic steroids or whatever. Basically, whether it's a phototherapy, all forms of treatments have been empirical, and all of them have been non-targeted immune suppression, which reduces the inflammation. And we know that there's a huge variation in the severity of atopic dermatitis depending on season and environmental factors, and of course depending on which part of the world the person is. And the next point is, of course, everybody here is an experienced dermatologist. We know that the domains of atopic dermatitis are very, very significant. It's not just the itching, it is the frequent and intense itch which is really troublesome in atopic dermatitis, which results in sleep disturbance, difficulty in falling asleep, and frequent awakening. We may be able to reduce the signs and symptoms for a short while, but it frequently persists and comes again and again and flares. There are other issues, for example, bacterial infections, viral infections, and fungal infections which come. The quality of life is significantly impaired. Of course, if you really observe the patient and take the questionnaire, you can demonstrate anxiety and depression, absenteeism and presenteeism. So rather than reading all these things, all that I would like to say is that, see, atopic dermatitis, especially if it is severe, is quite a nightmare. We know that the patient cannot sleep, cannot stop scratching himself or herself, finds it difficult to go to school, finds it difficult to socialize, finds it difficult to study or be productive as a child, finds an extremely difficult time taking care of their skin. They keep getting advice left, right and center. We all know the parental pressure that atopic dermatitis patients go through. Don't eat this, don't eat that, and really the entire family is under tremendous strain. And many families break up, and there are stories of suicide, and not only that, even homicide of late, because of atopic dermatitis and the fact that it has not been successfully treated. Therefore, we have one condition in dermatology as practicing physicians who are actually asked to provide a relief, and there's a crying need for some kind of new treatment in this condition. So let me talk about the prevalence. The prevalence of atopic dermatitis in adults is estimated to be between 2 to 10%. This 2 to 10% is a huge variation. This huge variation is very, very significant because atopic dermatitis, the definition is one of the issues. Diagnosing as per the American Academy of Dermatology modified criteria currently. Second, depending on the geographic location and depending on the climate, the prevalence is significantly different. 70 to 85% of adult atopic dermatitis cases, if you take a history, would have had atopic dermatitis when they were children also. Of course, adult onset atopic dermatitis is also well known, but still by and large, most of them have had atopic dermatitis since childhood. So when you talk about prevalence in the United States, adult atopic dermatitis is around 3.2%, of which moderate to severe is 1.47%, and moderate to severe atopic dermatitis which is diagnosed, treated and uncontrolled on current therapy is 0.7%. So to put it in a nutshell, the prevalence of atopic dermatitis is quite significant, and in terms of figures is more than that of psoriasis. In terms of moderate to severe atopic dermatitis also, the prevalence is quite significant. 1.47% of moderate to severe atopic dermatitis is a huge figure in the population, and which is uncontrolled on current therapy, 0.7%. That means you have a huge need of patients, or a pool of patients who need to be really treated. When you look at the European Union statistics, you find quite a significant difference. Possibly this point, that is severe atopic dermatitis, contraindicated, intolerant or inadequate response to cyclosporin is 0.02 to 0.08. See, cyclosporin is possibly one of the only medications which is really successful in managing atopic dermatitis. It's not licensed in the United States. and it's licensed in the European Union, and that makes the difference in the statistics from 0.7% to 0.02. So that is the impact of cyclosporin. Of course, we all know that cyclosporin cannot be used for a very long period of time, and it has many other issues. So, of course, as postgraduates and as young dermatologists, we have been discussing about the cause of atopic dermatitis. There's a clear-cut genetic background, and there's an inside-out hypothesis, there's an outside-in hypothesis. Seriously speaking, there are multiple factors: a barrier defect in the skin, an immunological alteration, and an environmental trigger. The triggering factors are very well known, and it's a strange issue. It's not exactly an allergy, and we all know that it can be triggered by climate change, by clothing, by environment, by irritants, by stress also for that matter, by skin infections. So the triggering factors actually trigger an inflammatory response in the skin, which forms an auto-inflammatory loop and goes on and on and on. The genetic factors of late, because of excellent advances in genotyping and in immunobiology, we know that the genotype of atopic dermatitis is quite varied, and one of the common issues in some patients is the filaggrin gene being deficient. Not in all, of course. You can have a filaggrin null gene, or you can have a filaggrin deficient gene, which results in reduced production of filaggrin in the skin, the barrier becoming damaged and becoming more exposed to the environmental irritants, setting up a loop of inflammation. Traditionally, the labeling or the names we have been giving to diseases have been changing almost every 50 years or 100 years. And as dermatologists, we all know that we are very fond of keeping on changing names or giving new names, and have in fact multiple names for each and every condition. From the days of Hippocrates, when we discovered that disease is not always divine intervention, but actually there is something which can be positive, to the last century, about 150 years ago, when we realized that skin diseases should be actually classified in terms of the morphology, that is papillosquamous, blistering, etc., etc., etc. We have entered possibly an era where we are going to start calling diseases by the genetic type or the chemical signature of what is happening in the inflammation in the skin. The reason for this kind of introduction is to tell you that, see, atopic dermatitis has a huge phenotypic variation in presentation. The Asian skin shows a psoriasiform appearance, especially in adult atopic dermatitis, and clearly it can be demonstrated that interleukin 17 and IL-17 plays a role in the Asian phenotype, whereas in the European phenotype, or in most of the cases, it is a Th2 type of response with interleukin 4 and interleukin 13 playing the major role. Therefore, we never know, maybe in another decade or so, the name atopic dermatitis itself might change to an IL-4, IL-13 disease or whatever. And the future is quite exciting. So patient burden, of course, the burden of atopic dermatitis is not only visible skin changes, not only visible skin redness, oozing, crusting, lichenification or thickening. It is the fact that it is persistent with frequent flares. Typical presentations, classical morphological presentations during infancy, during childhood, during adulthood are all well known. I don't want to waste time on this slide. Of course, secondary skin infections are common in patients with atopic dermatitis. Bacterial infections, Staph aureus and its role, the skin microbiome in atopic dermatitis, the fact that viral infections, we know Molluscum contagiosum is very common in atopics, and it becomes giant and it spreads more easily. Eczema herpeticum, eczema vaccinatum, these are all common. Susceptibility to fungal infections, especially the facial exacerbation in atopic dermatitis has been linked to Malassezia furfur. And there is a small niche of a few patients who do respond to antifungal therapy, especially when they have persistent facial flares. So the key points here are we are dealing with a disease which persists for decades. We are dealing with a disease which has not only physical symptoms but has intense itching and intense disturbance of quality of life, and has a huge psychological impact, an impact on work, on productivity, on sexual issues in adults, and a very major impact in the quality of life. And we are dealing with a disease with a lot of comorbidities, including systemic inflammation, asthma, etc. And let me go on to the next topic. What is dupilumab? We are in the era since the late 20th century of monoclonal antibodies. And monoclonal antibodies have actually taken over the management of many conditions, not only inflammatory, in fact even neoplastic of late. And the interesting thing about dupilumab is that it's a fully human monoclonal antibody against the alpha subunit of interleukin-4 receptor, which co-hosts the IL-13 molecule also. And by blocking this, you can downregulate interleukin-4 and 13 and demonstrate the inflammatory mediators which are released after this becoming much less in the skin. And being a fully human monoclonal antibody, the immunogenicity and other issues related with dupilumab are much less. So this is a depiction of the pathophysiology of atopic dermatitis. Like I said, the inside out and outside in hypothesis, the fact that we are dealing with a genotypic condition which actually results in not only an alteration of the skin barrier but makes triggering factors induce a loop of inflammation which is going on and on and on. So very clearly you can see that there is a barrier defect in the skin, there is an itch, scratch itch cycle being maintained, environmental factors and allergens and the barrier defects result in the Th2 cells producing the cytokines like IL-4 and IL-13 and 31, and dupilumab blocks IL-4 and IL-13 and works not only in the normal skin but acute lesional skin and chronic lesional skin. The fact that dupilumab acts in all the parts, the normal skin, the acute eczema and the chronic eczema, the skin, is highly significant, because we are not only talking about an improvement in the acute phase but also in the lichenification and also in the prevention of relapses when we use dupilumab. So what is the current treatment? How are we managing atopic dermatitis? We manage atopic dermatitis by giving lectures. That's what I have observed. And we are fed up with these lectures, and the patients are also fed up with these lectures. We take pride in counseling, which is important. We take pride in demonstrating to the patient the need of having to use topical corticosteroids. We take time to try and dispel steroid phobia. We take time to tell the patient that fingertip unit is important and you need to use one fingertip unit to cover 2 palm areas. We take time, and we take time to teach our nurses, to counsel them on how to avoid environmental allergens, how to avoid the triggering factors. We take time in showing them how to use a wet wrap. We take time to show them how to use the bleach bath. And basically, it's a very time sensitive issue. Most of the time, atopic dermatitis is managed by us and by nurses by giving talks and counseling. In spite of that, we know that atopic dermatitis is pretty difficult to control always. The flares are frequent, and in spite of using, for example, the topical calcineurin inhibitors to reduce the flares, and even to use the topical corticosteroids on apparently normal skin intermittently to reduce the flares, we still end up with flares. So the treatment ladder for atopic dermatitis is primarily hydration and moisturization, using low potency topical corticosteroids and calcineurin inhibitors, and then going up the ladder in the strength of these. And in case where there is inadequate response, we do end up sometimes giving phototherapy, especially narrowband UVB. One of the issues with phototherapy is the difficulty of the patient to come on a regular basis, and the difficulty in treating young children, and the fact that you can't go on with this forever. Okay? So, when do we decide that a patient requires systemic therapy? There have been many articles on this issue. Atopic dermatitis is a highly dynamic condition. You need certain objective and subjective measures of disease burden which could qualify a patient for systemic therapy. But these objective and subjective measures are also dynamic in nature. One day you take a patient's photograph and you show an exacerbation. Believe me, within a week he may be better. And when you inquire, there might have been a serious triggering factor, or there might have been non-compliance to the traditional way of treatment. Therefore, a one point or single point assessment of atopic dermatitis is not ideal. Ideally, the assessment should include a period of time, and patient-reported severity measures are more important than static measures. So, having discussed about the traditional ways of treatment, and having gone through the fact that we keep giving lectures too much, what is the crying need of the hour? The crying need of the hour is actually a targeted treatment targeting specific drivers of atopic dermatitis is possible now, because we know that the Th2 mechanism, especially interleukin 4 and 13, is one of the key drivers of atopic dermatitis, and we are in a position to use a tool, a medicine which can block this. So targeted treatment is possible. Ideally, what is one of the biggest issues in atopic dermatitis? In fact, if you take a DLQA score, one of the last points in a DLQA is how much are you fed up with the treatment. So it's a very messy process, having to use creams and lotions and bleach bath treatment and moisturizer, and being adherent to it is very tedious issue. So if you have a systemic treatment which reduces the need for time-consuming application of current treatments, and which is easier to do, of course we need it. If we demonstrate that the efficiency or efficacy of this medicine is high, of course that's of paramount importance. And if it turns out that this is quite a safe medication, it's even more of a point. So going back to this treatment ladder and discussion about when a patient needs systemic treatment. If a patient clearly demonstrates by objective and subjective measures a moderate to severe atopic dermatitis or a severe atopic dermatitis, and he or she cannot be controlled with conventional treatments, or there are unacceptable side effects with conventional treatments, then the patient becomes a candidate for systemic treatment. Remember, at each and every point, reconsider the diagnosis, consider scabies, consider dermatophytosis, consider doing a patch test before you can go on to systemic medication. And once you decide on systemic medication, what are our options? To be frank, like I said, in the US, cyclosporin is not licensed. In the European Union, cyclosporin is licensed. All other medications, whether you are talking about azathioprine or methotrexate or mycophenolate, mofetil, all those are not licensed for atopic dermatitis. So if we are touching any of them, we are doing something which is off-label. Dermatologists love methotrexate. I know, I have also treated patients with methotrexate, but then it's not licensed. So if you use any of the unlicensed systemic medications for atopic dermatitis and end up with trouble, we will find it difficult to defend ourselves. Except cyclosporin, and cyclosporin is highly effective in atopic dermatitis, but we can't go on and on cyclosporin for a long time. The number of drug interactions and the number of other issues with cyclosporin, including the renal issue, hypertension, and all of that, you know. So, having excluded all those things, we do have currently a new medication which is licensed and which is highly effective in the management of moderate to severe atopic dermatitis in adults. And I believe a license has been given today by the FDA for patients who are in the teenagers, right from 12 to 17 also. So, what is it that we need to know as dermatologists in UAE to be in a position to prescribe Dupixent or Lipolizumab? So, atopic dermatitis assessment tools, this is one of the most important things. When we talk to an insurance company, we need to tell them, look, we have a clear-cut diagnosis. Atopic dermatitis as per the American Academy of Dermatology modified criteria, or as per the UK Working Party diagnostic criteria, we are sure about the diagnosis. You don't need a biopsy for atopic dermatitis by and large. Of course, you need to do a severity measurement. The most commonly used severity scales are the SCORAD, that is the severity scoring of atopic dermatitis, the EASI, that is Eczema Area Severity Index, the Investigator's Global Assessment, and the VAS or NRS, the Visual Analog Scale or the Numeric Rating Scale for pruritus. So let's go one by one. The number of tools available for assessing the severity of atopic dermatitis are innumerable, and that has been one of the problems that as practitioners we are finding it difficult. Second is, we have spent a lot of time learning to counsel patients on atopic dermatitis. We have learned a lot of time teaching our patients on how to, teaching our nurses how to counsel patients, and we have taken a lot of time to learn how to do a trap. But this is absolutely important in current day practice. So we need to know how to score atopic dermatitis. So unless you are able to score atopic dermatitis, we cannot fight with the insurance companies. We need to know how to do a SCORAD. What is a SCORAD? A SCORAD calculation assesses three components. It assesses extent of disease with a maximum of 100%. See, each area is assigned a different percentage, and we need to assess how much percentage of that area is affected. Then assess the intensity of items like erythema on a 0 to 3 scale, edema, papulation, oozing, crusting, excoriation, lichenification, dryness, and also assess the subjective symptoms on a VAS scale of 0 to 10. Pruritus and sleep loss. The calculation is extent of disease divided by 5 plus 7B into B divided by 2 plus C. Maximum score is 3. Don't get worried about all this jing bang right now. The jing bang becomes very easy, believe me. Okay, the SCORAD is actually an objective and a subjective measurement. So what is the speciality about this? We are not only objectively looking at the erythema, edema, the lichenification, etc., but we are also factoring in the lack of sleep and the itching that happens in atopic dermatitis. And that is why the SCORAD is one of the most favored assessment tools. The objective SCORAD is actually a SCORAD which removes the itching scale and the lack of sleep scale. The minimal clinical important difference to demonstrate an improvement is 8.7 in the classical SCORAD and 8.2 in the objective SCORAD. So being a composite score, what happens is it's a widely validated tool, and it's one of those important things that we need to measure if we need to assess a patient. Of course, a patient, I forgot what is the word. Anyway, there's a mobile app which lets the patient to do it on their own. That's called the patient-oriented SCORAD also. And this, I would like you to concentrate only on this, not on anything else. How do I highlight this? See this. If you click this link, can I click that? Yeah, it's working. It's working there, but not there. there's an online tool. You click the online tool, you get the score ad. It's very easy for us to fill up. Once you fill up, you get the score. So we need not worry too much about the gym plan that I talked about till now. And this is a validated tool, and it's very easy to do. So it's online, and the score ad calculator is easy for us to download, and it's something very, very easy to do. And I do it almost on a daily basis for my psoriasis patients. This online tool cuts down the time of evaluation for score ad to less than 2-3 minutes. So we don't have to spend more than 2-3 minutes on calculating a score ad for a patient. So that's it. Okay. Next is the eczema area severity index. The EASI score is very popular in Europe, not so popular in the United States, and EASI score is very easy. It's exactly like the PASI. So only thing is except the only issue is that we are going to assess erythema, infiltration, papillation, excoriation, and lichenification when we assess atopic dermatitis. That's the only difference. So the calculation is also exactly like the PASI, and the calculation will be from 0 to 72. So once we get used to it, once we have a form for it, this is also pretty easy to do. And interpretation is also very easy. Of course, 0 is clear. 0.1 to 1 is almost clear. 1.1 mild, moderate, severe, and very severe. So overall, the difference that has to be demonstrated to show an improvement is 6.6. Like score at ideal.